So let us get started. Now we have Barbara Mahon from the Gates Foundation. Please, Barbara.
The best way to get started is to get started, right? Thank you. I just wanted to, like everyone else, thank you for the incredible hospitality. This has been a wonderful event, a fantastic group of people, very interesting, and the setting and the events and the music has just been beyond. So thank you so much. So I work at the Gates Foundation, but I spent most of my career at US CDC as an epidemiologist working on public health surveillance, outbreak response, cholera in Haiti, Ebola in West Africa, COVID-19, many, many other outbreaks. And so I wanted to talk a little bit about just surveillance. And this may be a bit simplistic, but I hope it's not too simplistic. I'm going to be touching on a number of themes that others have brought up. So the purpose of public health surveillance is to inform decision-making. Surveillance has been called data for action, and I think that's a good way to think about it. Anything that, any information we're collecting that isn't going to be used for decision-making or for action is probably not worth the resources needed to collect. So in a pandemic, we will all agree that it is important to collect information on cases and deaths. And in high-income countries during COVID-19, for the most part, surges and declines in disease were apparent. This graph shows the first 4 years of the pandemic, and you can see when the public health emergency was declared, and you can see the Omicron surge, you can see when the public health emergency was declared over. There are some caveats to this graph. Of course, early in the pandemic, testing was less available, but for the most part, you could see the increases and the decreases in high-income countries. I've shown here the US in green, Italy I think is in black, and the UK in brown, and these are numbers of cases, so the peaks are higher for the US because it's a bigger country. But the point is that basically you could see those patterns, and these data were used for decision-making about non-pharmaceutical interventions, to keep the public informed about the trajectory of the pandemic, and so forth. In lower-income countries, they were much less able to track the pandemic. So in this slide, the top pink line is all high-income countries. High-income countries represent about 18% of the world's population, but they contributed more than 50% of the cases that were reported to WHO. The line below that, the sort of brick-colored line, is lower middle-income countries, and that line is quite a bit lower, even though lower middle-income countries represent 35% of the world's population, twice as many people. And then the bottom line, which I think you really can't even see, the bottom purple line is low-income countries. Now, the pandemic affected the whole world, countries at all income levels, but the ability of countries to track the pandemic was enormously variable. And so you have to think about the process that leads to a reported case. Tests need to be available. People need to be able to access those tests through healthcare or otherwise. Then the mechanisms have to exist to report those results, those positive results, to public health authorities and then on to WHO. So you might think that deaths would be easier to track. If we have problems with cases, maybe we could track deaths. But in many countries, information is severely lacking about the numbers of deaths on the left. This is from 2019, but the pattern hasn't really changed since then. Where you can see in many countries in Africa, less than 20% of deaths are reported at all, registered at all. And then in the purple on the right, the causes of death are even more commonly lacking. So in sum, for the pandemic, COVID-19 death counts were extremely incomplete in some countries. And what this map shows is the ratio of the estimated excess mortality to the number of reported COVID-19 cases. And you can see that in much of Southeastern and South Asia, Sub-Saharan Africa, even some countries in Latin America, there were more than 20 excess deaths for every reported COVID-19 case. Now, some of those could have been from deaths from other causes, deaths due to disruption of routine health services, or deaths due to the impacts of poverty and lockdowns. But most of those were due to COVID-19 cases that were not diagnosed and were not reported. So for the next pandemic, we really need to do better, because we're going to need information from all countries for the next one, just as we did for the last one. So I've spent these first few minutes talking about how difficult it is and how variable the reporting of cases and deaths is. But in a pandemic, we need a lot more information than simply cases and deaths, as difficult as those are. So in my next few minutes, I want to talk about the questions that surveillance needs to inform before a pandemic, during a pandemic, and after a pandemic. So before a pandemic, the question is essentially, is a new health threat emerging? This is the question that is running in the background all the time. And the way we address that is through outbreak detection, early warning surveillance. And this can happen in a number of different ways. It can happen through, classically, an astute clinician who realizes that they're seeing something that isn't right, and they report it to the health authorities. It can happen through event-based surveillance for clusters of deaths that are unexplained, even for clusters of livestock deaths that are unexplained. It can happen sometimes through indicator-based surveillance, where tracking cholera deaths and seeing an increase. Or it can happen now through wastewater surveillance for certain pathogens that are known and are under wastewater surveillance. But regardless of how it happens, the earlier the better, because as the more time passes and the more cases can accrue, the more difficult it is to initiate a response that's able to limit cases and deaths and potentially prevent a pandemic. So that early warning and timely response is critical. And one approach, I'm not saying that this is the only one, but one approach that has been gaining a lot of traction recently for operationalizing detection and response is what's called 717. This has been promulgated by Resolve to Save Lives, Tom Frieden's organization. The 7 means it's 7 days from the initial event until the detection of that event, 1 day to report the event to the appropriate health authorities, and then 7 days to initiate an effective early response. And you can see this is first proposed just a couple of years ago, has been really taken up in a number of countries across the world, including at the subnational level, even in some cities in the United States, and is now used as part of the results framework for the Pandemic Fund, and has been taken up by the Africa region, and I think is really a promising way of operationalizing early warning surveillance. So I'm not a policy expert or an economist, so I'm a little bit intimidated in this audience. But I've tried to just put down some thoughts for each of these phases about what they mean, what these public health and epidemiologic needs mean for governance and for policy. So for early warning surveillance, you need the political will to have the systems in place, adequate population trust for people to be willing to report when an event occurs, good enough population coverage, including in remote and low-income areas, to have early detection, and then ongoing adequate resources for reporting and response. And of course, going back to the third one, the very areas that Eddie was telling us were the areas of greatest risk of a spillover event are often the areas with the least ability to actually implement early warning surveillance. So then surveillance during a pandemic. During a pandemic, there are a host of questions arise that go well beyond traditional disease surveillance. So I've listed some of them here. This is a slide that I've modified from the Berlin Hub's slide that I love. But questions like, is there human-to-human transmission? Are our healthcare facilities coping? Are our ICUs overwhelmed? If there's a vaccine, is the vaccine effective? Are new variants emerging? Are our therapeutics working? And to answer these questions, we need other kinds of information. So I like this slide, which comes from Mark Lipsich's work, formerly at Harvard, now at Stanford, where he's listed some of the decisions that need to be made during a pandemic on the left, the scale of the response, the targeting of population protection measures, balance of investments across different types of interventions, the kinds of balance of different sorts of impacts of the epidemic that we were hearing about last year. And then in the middle, the different kinds of knowledge or evidence that's needed to make well-informed decisions about these. So everything from transmissibility of the pathogen to severity, to the expected duration of the pandemic, to the effectiveness of interventions, and so forth. And then that knowledge, in turn, draws flexibly from a number of different surveillance inputs or data inputs that go beyond case counts and include things like outbreak investigations or monitoring stockpiles of PPE or monitoring livestock. I'm mentioning just a few. I don't want to read through all of them. So to bring all of this information together and to analyze it fast enough to inform the decisions that need to be made is really difficult, and it takes resources. So for surveillance during a pandemic, collaboration and information sharing across government ministries becomes critically important. Also across sectors of the economy and between countries, and we've talked a lot about that here. That's a need that's somewhat more in the background during peacetime, but during a crisis becomes critically important and is very hard to stand up in real time. Again, adequate communication is needed to explain the changing situation to the public and in a way that they can understand and discuss and ideally cooperate with. And then adequate ongoing resources for the collection and the analysis and the dissemination of all of this information. This is really I think Alessandro was talking about this yesterday, it might have been someone else. It takes a lot of expertise and money to make this happen. Then surveillance after a pandemic. Eventually, we move out of the emergency phase of the pandemic. And the way I think about this is that once a very high proportion of the population, let's say 98% of the population, has had one or more immunizing events, whether that's vaccination or whether that's infection, we are now moving out of the emergency phase. The pathogen may still be an important public health threat, as COVID was and is, but we're out of the emergency phase and need to move toward thinking about how do we incorporate this new threat into our routine public health and medical practices. I want to show just one slide about this. After the public health emergency was, as it was being taken down in the United States, I was incident manager at that point, and we published this infographic that accompanied an article in the Morbidity and Mortality Weekly Report, that's CDC's weekly sort of news, scientific news publication. And we showed how we proposed to use data streams to track medically significant consequences of COVID, to track new variants. And what isn't on this slide is to track wastewater. What isn't on this slide is trying to track every infection, regardless of whether it caused symptoms. But we got a huge amount of pushback from people who said, why aren't you trying to track every infection? And the reason is that at that point, in the post-emergency phase, there aren't public health decisions to be made based on every single infection. That was relevant only early in the pandemic, where there was a possibility still, a hope of eradicating the virus. So for surveillance after a pandemic, you need the political will to rationalize the surveillance approaches for a post-emergency situation. It seems very easy to stop doing emergency response things, but as somebody I think just spoke about, I think it was Villa just spoke about in the last session, it's not so easy to stop doing even quite expensive things. And again, adequate communication. So this is essentially my last slide. Before I close, I wanted to talk about how newer technologies, and this is really a focus of a lot of my work at the Gates Foundation now, can efficiently complement traditional surveillance approaches. And we are at the foundation are working with Africa CDC and with others on trying to get the maximum benefit of these technologies in sub-Saharan Africa and in South Asia, but they've been taken up in many higher income countries as well. So wastewater surveillance has an important role for early warning. Electronic medical record-based case surveillance can, with modern digital analytic tools, AI, can be quite useful for tracking symptomatic cases. Multi-pathogen serosurveillance, where you can test for population immunity with a sample of the population using just a finger stick, just a dried blood spot, can monitor population immunity at a very low cost. Genomic surveillance to track evolution of viruses and other pathogens. And then there's also quite a few advances in mortality surveillance. The situation in Africa is improving, slowly but surely. So in summary, public health surveillance is, it really needs to be laser focused on the information that's needed for decision making. And those information needs change over the course of a pandemic. The information streams need to be able to be flexible and to surge when needed and to be stood down when needed. Common themes across the pandemic course are the need for political will, for trust, and for adequate resources. And we've talked about this across this week. So I'm repeating what you, I think, already believe. Newer tools like wastewater surveillance, genomics, artificial intelligence are really important. And then good decision-making for the next pandemic. Ideally, ideally we will have, but we certainly will need high-quality information from the whole world, not just from the high-income world. I will stop there. Thank you so much.